Thank you very much. It's an honor. It's humbling to be invited to speak to you. Thank you for having me. Thank you to the bishop and the administration for giving me a few minutes here to speak to you. I want to tell you just a little bit about myself. I'm from Southern California. I grew up in a pretty large family. My dad did construction. He has an 8th grade education. And I'm thankful for a teacher in high school who pulled me aside and said, "Hey, you got a talent. What do you want to do?" I said, "I want to be a doctor." She said, "What are you going to do?" She said, "Have you taken this test? Have you done this?" I said, "No, I didn't know I was supposed to." And she said, "Well, this is what you need to do." And she pulled me aside and she guided me. And I'm so thankful for that teacher. And I've gone back and I've thanked her because she's directed me. And without her help, I wouldn't have done the things I needed to do. I knew coming in here, first of all, there's a great spirit here. I appreciate it, but I hope I don't bring it down. So thank you for having me. I knew coming in that there were going to be people here that knew people who had been affected by prostate cancer, that had been affected by prostate cancer, and had lost loved ones from prostate cancer. And I want to tell you a little bit about prostate cancer, a little bit about our healthcare system. About 7 years ago, I had a little bit of hope. There was talk of this Affordable Care Act, and I had been frustrated. I see my patients, and they would come in and they'd say, "Here's my problem," and I'd say, "Yeah, I got this great thing that can help you, but unfortunately your insurance doesn't pay for it, or you don't have insurance." And it was frustrating as a physician who goes into a profession to help people and to have compassion and know that there's something there that's not affordable. And so I was frustrated, and so I had hope with this Affordable Care Act. And there were people that were saying, there's going to be death panels, and I thought, no, that's kind of crazy. This talk of that, I didn't think that was going to happen. And they didn't do it, and it passed, and I was disappointed. And some of my hope was that we could free this whole process up from government, from companies, from drug companies, from insurance, from hospitals, and just allow good health care to people. And it just hasn't panned out the way I had hoped it would. But one of the things that came out of this is a group called the U.S. Preventive Service Task Force. So one of the ways we can help get everybody to afford health care is that we can say, what makes sense? What are things that work? What are things that don't work? And so there was a panel that was created, and they were appointed people, and there was no one on this who was a cancer doctor. This was some administrators, some number crunchers, a couple of retired doctors, and they were charged with the duty to look for ways of saving money. How do we screen for cancers? How do we screen for different cancers? And are we doing it too much? And so I didn't think much about it. About 6 years ago, this group, the SWPCF, said, "You know what? We're screening too much for breast cancer, and we're doing too much, and we need to cut back on breast cancer." And I just assumed that was good science. And women, thank heavens for women, they said, "This is garbage, no." And the women backed them down, and they backed off on it. And then the next year they said, "Well, we're doing too much cervical cancer screening." And again, they didn't learn their lesson. The women just went off on them, and they backed down on it. 3 years ago, they said, "You know what? We're doing too much screening for prostate cancer." And what did the men do? The men said, "Okay, good." And we didn't say anything. And I trusted them to think for me, but as a urologist, all of a sudden this affected what I'm teaching my patients, what I'm telling my patients. The patients I see who are dying from a disease, the patients who have died from a disease. And so I looked into it, and I read their 40-page document that they had. And they said that they had reviewed over 300 articles to make this recommendation. And they focused on 6 of them. And so I looked into it, and I read those 6 articles, and I had read a bunch of the other articles also. But these 6 articles, there were some that were very favorable for screening, for checking PSAs, doing rectal exams, and screening for prostate cancer. But there were 2 of them that were out of the U.S., and these two articles compared 2 groups, and they said, let's take one group and we're going to screen them for cancer, and another group and we're not going to screen them for cancer. We're going to see how many people died of prostate cancer 5 years later. And lo and behold, they said, well, there's no difference. We don't recommend screening for prostate cancer. And 2 of those articles were like that. So I looked at these articles. Well, it turns out that in the group that wasn't being screened, their doctors were being good. Their doctors were doing exams. They were checking PSAs. Half the people who were supposed to be not getting screened in the study were getting screened, so it was kind of garbage data. If you look at, if I were to give you an example about smoking, if I were to say, let's see if smoking causes lung cancer and heart disease, and I took a group of 100 people over here and 100 people over here, and I said, all right, you 100 people, you smoke starting at age 50, and you 100 people, you don't smoke, but half of you go and work in a bar where there is tobacco. And then 5 years from now, let's see how many people are dead of lung cancer. You know what the difference is? It'd be none. You would not be able to prove that smoking causes lung cancer, but we know it does. We wouldn't be able to prove that smoking causes heart disease, but it does. It takes a longer time. So these studies were very frustrating. This year, in the last 10 years, this is a graph I was discussing with Fred. I wish he could be here, but they looked at over the last 10 years of all the cancers that affect people, which one have we made the most progress in decreasing death rates? You know what number one drop in death rate is? Prostate cancer. It's the number one thing that we've helped in the science that we do. This year, so about 3 years ago, some doctors cut back on screening. They weren't recommending PSAs. They'll ask their patients, do you want a rectal exam? What do you think the guy's going to say? Yeah, no, I no, thank you. If you're giving them an option, they're going to say no. I don't want one. I have 2 uncles that had prostate cancer, and so I get screened every year. But this year, there have been 2 reports out. One of them came out and said that the cancers that the biopsies that we're doing, we're finding more cancers, and the cancers that we're finding, they're worse. They're higher grade, they're higher stage. Why? Because we didn't find them 3 years ago, and now they have symptoms, and now it's in their bone, it's in their lymph node, it's causing a symptom. Catch it while it's early. Now they're telling us not to check it. They're actually saying don't check it, recommending not to check it. Now, I'm not a conspiracy theorist, but let's look at who gets prostate cancer. Older men get prostate cancer. And you think, oh, well, most of the guys who get prostate cancer are 80, they're gonna die of something else, it doesn't matter. The average age that people die, that men die of prostate cancer is 64. That's a young man. It's a young man. Black men are 1.6 times more likely to get prostate cancer and 2.5 more times to die of the disease. This is a deadly disease. It is the number 2 cancer killer of men in America, and they put it out on the news, and they put it out as if this is something everybody gets, don't worry about it, nothing's going to happen. It's the number 2 cancer killer of men in America, and we've cut that death rate in half in the last 15 years by screening, and now they don't want us to. There's a group called the CMS. Please remember that. CMS is a group that makes recommendations, and they just made a recommendation earlier this year that doctors who check for prostate cancer, that do PSAs and screen for prostate cancer, will be punished financially. They'll get paid less if they screen. Now, just last week, they backed off on it. They're going to reconsider it. But this is going to go through. Write your congressman. Talk to somebody. Make a noise about it. They're trying to make it where your doctor's going to be punished. Do you have a say in it? No. You say, doctor, I want to get screened, and they're going to find some reason not to because they're going to lose money if they screen you. It's true that most men who get prostate cancer do not die of the disease. Most men have a low grade or a low stage form that is not really aggressive. But number 2 cancer killer, 2.5 times more likely to kill black men. It is a scary disease. Well, what do we need to do? We need to be better at who we select. If we go out and we select men who are 95 years old, who are on oxygen, who are going to die, that's not a person to screen for prostate cancer. If we're looking at men who have really bad health, they're not going to live 10 years, probably not a person to screen for prostate cancer. But who should we screen for prostate cancer? Probably you and you and you, everybody down here. Every guy should Just about every guy here should be screened for prostate cancer. You're at risk. How many people in your family? 5? 5 members of your family? It's a genetic-based disease, and it affects all of us. I have 2 uncles. I'm a little bit nervous about it. When we screen, we need to be better at biopsying. We need to be better at treating. And we're getting better. We're getting more selective. We're able to do genetic testing on the cancers, and we send that off, and it tells us, is this a cancer that's going to want to grow fast? Is it a cancer that wants to spread? And we can do tests like that and say, no, you got the kind that we're just going to watch. And then the other ones, we can say, wow, this is a cancer that, even though we caught it early, this looks like one that it's going to want to jump ship and go to a bone or a lymph node. And these are the ones, this is the kind of stuff we can do now. We're better at treating it. We treat it with robotic surgery. We treat it with high-tech radiation, proton beam, IMRT. There's a lot of new treatments that have a lot fewer side effects than they did 15 years ago. We have a screening on June 11th, which is just the week before Father's Day. It's free. I am thankful for Fred to ask me to help out with this, and I was more than happy to offer my office. We have a nice office. It's over in Glendale. Every man here is welcome to be there. I would love to have you there. It's free. We get sponsors for the blood test. I get volunteers. Not just my practice. I get some doctors from other practices. I've been inviting them in. You're going to get an exam. You're going to get a blood test, and you'll get a call in a week with the results. This is a free screening, and I invite the men to come. And I invite the women to push their husbands, their fathers, their son, whatever it is. If you're over 40, you need to get screened. So please come out. And then take it upon yourself. Don't let... I was foolish. I looked at what the U.S. Preventive Service Task Force said about breast cancer, and I said, they must know what they're talking about. I looked at what they said about cervical cancer, and I said, they must know what they're talking about. But when it affected me, I said, wait a second. It affected my patients. I said, wait a second. This is wrong. Don't let people think for you. You got to have trust in your doctor, but know that this is something that you can take control of. It's simple. It's free. Get screened. Get it before something happens. Now, the vast majority of people that get screened don't have cancer. I mean, that's great. If you don't have it, you got a year, check it again in a year. The people who do have high abnormal exams, abnormal PSAs, they might get a biopsy. We might just check it again a couple months later. It doesn't mean that it commits you to going downstream with everything. It doesn't mean that you have cancer. And if you have cancer, it's treatable, it's curable. We cure over 90%. Back in the 1950s or 40s, when a person had prostate cancer and they ended up with, when they had prostate cancer, they got in the bones. They went to a pain ward where they got morphine until they died. When in the 50s, they discovered that there's some hormonal manipulation that could help. 85% of people responded to that. Unfortunately, when that treatment wore off, you had 8 months to live. Today, we have all kinds of new drugs that work on it. They work on it early. They work on it better. We have better treatments. We catch it earlier, and we are able to save lives. We have cut the number of people who have lost their lives from prostate cancer over 50% per year, and yet we see a little bit of bump this year, and I am scared about it. Please take it into your own hand. Write your congressman. Come get screened. Tell your friends to get screened. Preach this. I know it's not the gospel of Christ, but it's the gospel. You know that Christ wants you to stay alive. He wants you to take care of yourself. And this is how you take care of yourself. So, thank you so much for having me here. I appreciate it.
And it is God's will that we will prosper and be in good health. Amen. We appreciate that presentation from Dr. Nelson. Remember the date, June 11th. I would encourage you, as the doctor did, to go and have yourself tested. It's free. It's free. So God bless you. Thank you again.